Hi everyone, I'm here with Siobhan Moyes. Siobhan, would you like to introduce yourself?
Yes, hi. I'm Siobhan Moyes. I'm the anatomy lead at Peninsula Medical School at the University of Plymouth. So I deal with the curriculum and teaching on the medical, radiography and physician associate programs there.
Okay, great. And Siobhan, you're involved in some really interesting topics. I'm sure a lot of people who are interested in anatomy would like to hear about. So can you tell us a little bit about the work that you're doing and how it kind of came to be?
Yeah, absolutely. So I've recently started a new project called Inclusivity in Anatomy Education. What is it and how do we make it happen? And it was it stemmed from a situation after lockdown where I finally got back into the anatomy teaching rooms and realised that on the background of the Black Lives Matters campaign, that actually all of our resources were white. There was very little representation of different skin tones, and that kind of was a real shock, a real wake up call. I felt awful about it for quite some time and was desperate to try and do something about it, because the thought of our students coming in and not seeing themselves or any aspect of their identity in our anatomy curriculum was just felt terrible. The difficulty I had was finding resources actually that were actually representative of people. And so I ended up having to collaborate with a fantastic company called Adam Rooley, who created all of our models. And they ended up developing dark-skinned models for us, which are now available to buy internationally, which is really exciting. But the fact that it took me in 2001 to get that sorted was a bit odd. It's quite surprising that it wasn't there available already. But so now it's not just skin tone, but also they're developing different shaped models and silhouettes and different bones, bony representation as well. So there's a bit more diversity in the range there. But we also worked really hard to try and make our anatomy curriculum more inclusive and using more diverse images, changing the way in which we use pronouns, talking about sex and gender and uncoupling those and ensuring that we kind of talked about the full range of diversity. And yeah, it's still a process. We're not there yet, and I'm not sure we ever will. But this research stemmed from us wanting to kind of understand what other people felt inclusion in anatomy actually meant, and whether they felt represented. So yeah, we sent out this pilot questionnaire, and it kind of gathered momentum, and it's now been answered by over 260 people in over 23 countries, and it's blown our mind how well received it's been. And so we've now got a lot of information, and we've found out that actually a third of staff and students that are involved in anatomy do not feel represented by their curricula, which is
That's it's not
it's not
good.
great, is it?
No, we found kind of
It's
similar
awful.
things at Nottingham, and I suppose it depends on whose perspective you're looking from, because some students do feel really well represented, but then others don't. But a third is, it's not great, and students do deserve to be represented, and I think it increases the engagement with resources and things. And then when you're thinking about that too, for everyone listening, that's not just students, that's patients also who probably aren't being represented too in the resource.
Mm.
Obviously, I talk from kind of a medical perspective as a medical student, and it is really shocking when you hear kind of statistics like that.
Yeah, absolutely. It's and it's not. It's about the person's whole identity. It's not limiting to skin tone or um, ethnicity, culture. It's all other facets of identity, and it's important for us to think about everybody. And, everyone is going to be engaging with healthcare. And so we should have representation of everyone. And unfortunately, the considered norm, in inverted commas, is white, slender male that's kind of quite young, and everything else, by definition, is not then normal. And I mean, I hate the word normal anyway, but that is basically an absolute minority and not the majority of the world's population represented in all textbooks and images and so on and so forth. And so we need to be doing something about it. And that's the key point of this research, is not just to see if there is a problem, we've identified that there is a problem, but also to see what the solutions are. And we've asked people about what their barriers were to kind of creating more inclusive curricula, what has worked well for them as well. But some of the biggest issues are around people being isolated and not having the connections and the community to be able to make the changes that they want to. And so part of this research is to try and build that community of practice. So all of these amazing anatomists that are running fantastic curricula all over the place can get together and share good practice. And if they're stuck with something and they're struggling with something, there'll be someone out there that's had the same issue, that's found a solution. So why not work together to try and make anatomy curricula all over the world better? Because we learn better from each other, don't we?
Definitely. And I think that's part of why I wanted to start this podcast, was to bring people together. Could you tell us a little bit more about your work with the virtual dissection curriculum?
Yeah, absolutely. So at Peninsula Medical School, we don't use cadaveric material. The programme was created in about 2002, before my time, but it was basically designed around an evidence-based curriculum, and everything that went in it had to be evidence-based. And there was surprisingly little evidence to show that you couldn't teach anatomy using other resources. And the fact that technology has developed so much recently, it offers lots of other opportunities to learn that may be better suited to certain individuals. Not everyone's a fan of dissection and prosection, and it's important to make sure that we can get healthcare professionals that, from all backgrounds and certain religious and cultural backgrounds really don't agree with the whole idea of round dissection, or it is quite challenging for them. So this offers an alternative. And so there's been a few meta-analyses that came out that show that you can learn anatomy through dissection, prosection, or without cadavers and still learn the same amount of anatomy. And we've certainly seen that with our curriculum. So we use a constructively aligned approach. So we teach anatomy in the way in which it's going to be seen in your patients. So typically, hopefully, your patients are alive. Fingers crossed.
Yeah.
Hopefully, all of their organs are inside their body as well. Fingers crossed. And hopefully they're able to talk with you and explain what's going on. Not always, obviously. But so we start from an outside-in way, really, and we start with a bit of surface anatomy. We use anatomical landmarks to identify the underlying tissues. We draw on the organs onto our amazing team of surface anatomy models who come in their swimwear and stand in the anatomical position and help tell the students whether their palpation skills are too tickly or pokey. And that helps the students kind of with their communication skills as well, and as well as their anatomy. We also include a lot of medical imaging. But we also have the anatomage system and complete anatomy as ways to kind of delve deeper into the finer details of the structures. So we will start students off with surface anatomy and then use the anatomical models to get that 3D spatial awareness. Yeah. And then once they understand how everything fits together, we will start with the virtual anatomy. And the thing that I like about this is that fact that you can actually start with nothing and build knowledge. So when we learn, we learn better if we kind of figure out what we know already and then add to that knowledge, rather than start with everything and then try and figure out what everything is as you come across it. So with the anatomized tables, and also to a certain extent with complete anatomy, we can start with the structures the students already know and then get them to add additional structures, see how they fit, then look at them in cross sections, see how they would look in imaging, and then start building a picture of the complexity that is the body, but starting simply and then building complexity.
Yeah, I think that's really interesting as well, because having the surface anatomy models, it allows you to kind of contextualize it in your actual teaching and how it will be in the future,
Absolutely.
which I think is really good. And having the surface anatomy models there, that's quite good too, because it is a more hands-on approach, I suppose, isn't it?
It is. And it's so lovely to hear their experiences as well. And, you know, a lot of the surface anatomy models that we have on the team are have had healthcare experiences in the past and are wanting to give back. And it's such a lovely opportunity for the students to chat with people that aren't, you know, their age or demographic or whatever, and just get a different life experience, find out, you know, how to improve their own communication skills, their own palpation skills, and, you know, understand someone who's, maybe a different age to them as well. So it's lovely to see the students start from their first ever session, where it's almost like they're trying to palpate using the force, and they like don't want to actually touch a person who's there in their swimwear because it's just socially awkward, to a couple of sessions in really kind of making sure the surface anatomy patient, the model is comfortable. They're not kind of twisting them into positions that you know aren't helpful, and you know it's just building that kind of rapport with them. It's just so nice to see them develop that way.
Yeah, definitely. And at Nottingham, we don't use the anatomage table, so I don't have any experience with them. But we did use complete anatomy, and I do think it was really helpful because it kind of just allows you to, like you said, build things up. So I can start with just the liver, and then I can add the arteries, then I can add the veins, then I can add the nerves, and it's not as kind of overwhelming, because when you do dissection, sometimes things don't look like how they look like in the textbooks on an actual person, and it can be kind of hard to distinguish them, and especially if our dissection skills aren't that great either, it can take quite a while to get to those parts too. So I think having prosections, dissections, as well as kind of online materials is really good to help you get that full knowledge.
Absolutely. I mean, there's a lot of evidence to show that adding digital anatomy to existing cadaveric curricula can be really beneficial to students' understanding of the anatomy. I mean, I personally, I learned through cadaveric anatomy, and I found it a huge privilege and absolutely fascinating. And I think that there is a place for all different approaches to learning, but it's nice to have a diverse range of curricula so that they're suited to a diverse range of people. So it's nice that one size doesn't fit all, as we know.
Yeah, definitely. Yeah, because with cadavers, obviously they are diverse, and you know they're people who have lived their lives, and like you said, you're privileged to be able to dissect them because they've donated their body, and that's kind of your first patient, I suppose, as a medical student.
Yeah.
And
absolutely.
then complete anatomy, it does have, because I know they updated kind of their phenotypes and things too, so you can change the skin tone and that sort of thing, which is good, because you might not see that diversity in the cadavers that you dissect with.
Yeah, and on the anatomage table, there's currently 4 different cadavers: 2 Korean, 2 American, 2 that are phenotypically male and 2 that are phenotypically female, and there's a lot of healthy variation and pathologies within them, so it's nice to be able to see all of the similar structures but how they look different in different people. So I think that range of diversity is really helpful, because you know, as we know, we may have very similar viscera and tissues, but they will look different in lots of different people. So it's nice to kind of be aware of that early on and not have that shock come to you when you see your first patient. So I guess you could say that our first patients are our team of surface anatomy models. So yeah, a slightly different approach, but it's just nice to have a variety of options for people.
No, definitely. I think kind of combining clinical skills in anatomy is really good because it does contextualise it in the way you will be using anatomy
Exactly.
in the future. So you've spoken a bit about your work with inclusivity in anatomy, and how have students at the university kind of reacted to this, and what were the findings when you were investigating their experiences of inclusivity?
So at our university or at all universities?
I say your university first and how it's developed, because I know you've done steps to develop your curriculum there to make it more diverse and inclusive.
Yeah, so as with a lot of anatomy curricula, there are people all over the world doing similar things. So I'm not trying to say that what we're doing is kind of like particularly unique and amazing, but we have absolutely been looking through our curricula to try and make it more inclusive. We have got the darker skinned anatomy models. We've tried to recruit a more diverse group of surface anatomy models. The southwest of England is not that culturally diverse, so it can be quite tricky. Our students are a more diverse cohort than the local population, so that has been a challenge. We've also adjusted our teaching materials to try and make sure that they are more representative. So all of the pictures aren't, the white slim male who's in their early 20s or something like that. So we have a wider variety of individuals represented, different ages, body shapes, that kind of thing. We've also adjusted the way in which we run some of our sessions as well. So, for example, with surface anatomy with surface anatomy sessions, we sometimes get students to palpate on each other as well, and that can be difficult for people with that like to remain modest. And so we've kind of adjusted sessions to try and make sure that students are still able to engage in those sessions in a way that is comfortable for them. But also for different types of neurodiversity, we've tried to create quieter areas for students to be able to do the activities. We're also looking in changing the teaching rooms and increasing kind of noise dampening to kind of stop the noise bouncing around quite so much, which I know can be kind of very distracting for some types of neurodivergence. So it's still a learning curve, and we're still trying to find ways to improve, but we're certainly tackling things like language, trying to ensure that we use pronouns appropriately, and we discuss eponyms as well, and why eponyms shouldn't necessarily be used, and some of the history behind certain eponyms and certain individuals that created certain procedures and using very dubious ethical approaches.
Yes, I've been looking at that recently. I didn't know what it was. So for anyone listening who doesn't know what an eponym is, it's basically when kind of a part of the body is named after the person who discovered it. And
discovered in inverted commas as well.
Yeah.
And they may not have been the person that discovered it, but they were the person who it's named after. And so it's very murky, very murky.
Especially with female genitalia, it's all named after males.
Yes.
A lot of the time. So I think it's trying to move away from using those terms and to more just the anatomical terminology rather than the people that they're named after.
Exactly. I had a very interesting conversation with a student who had looked into the etymology of all of the different slang terms for the vagina. And apparently every single one except one is based in receiving something, being a sheath for a sword, and all of those. So it's all in relation to the male anatomy, which was quite interesting. And the only one that isn't is the 4-letter word that we absolutely can't say on air. I'm not going to drop that bomb. But I find that really quite interesting.
No, that is definitely
so I think, the more that we learn about where the language comes from and where the research has come from, and how representative or not it is, the more we can kind of challenge our misconceptions and address them. And I think it just sparks that conversation, doesn't it? And I think those conversations are really difficult. They're awkward, they're messy. We don't have all of the information always, but I think they're important to have so that we can shape what we do in the future. So we acknowledge the fact that the data that we have is incomplete and is not necessarily representative. And then that encourages people to take up that challenge to identify what the actual data is, and a way of creating more inclusive research strategies that actually engage other people and diverse populations in the research itself, so it actually can positively benefit more people in the future. So it is difficult, and the language, it changes all the time, and it is really difficult to keep up. And so from a lecturer perspective and the lead in anatomy perspective, it is difficult, because every time you feel like you've made a change and you feel like you're addressing something, then actually there is a change in the nuance of the language, and it's understandable, because we are in a state of flux at the moment, and I'm sure that the language will kind of settle down, in a few years for certain topics. But we just have to ride that wave and do the best we can, and just be open to changing it as and when we need to, really.
Yeah, so I know, for example, when I was doing my dissertation last year, the university data that I was using was still using the term BAME, and we don't use that term really, or kind of phasing that term out. So it's interesting, because you've still got to kind of use, when you're referring to those sources, you have to use the terminology that the sources are using. But trying to move more towards, I kind of use like ethnically minoritized, racially minoritized, because ethnic minorities in the UK or ethnic minorities in the UK, they're kind of a global majority. So that's more contextualizing the language that we're using, which I think is really important. But you're completely right, it's always changing, and it's just about keeping up to date with it, I think. And if someone says the wrong thing with the right intention, I think it's more about education, rather than kind of calling someone out, or that sort of thing, about educating people.
Absolutely. And I think it's making people comfortable to ask the questions, because if you're working with patients, you don't know their life experience, you don't know their preference, and so you have to ask them. You can't make assumptions, but it is awkward to. It seems almost impolite to be asking certain questions, and actually it's getting used to being able to ask those questions that are important for that person's healthcare, in a way that is supportive and appropriate. And so yes, practicing that in a safe environment within a teaching class is kind of a good first step, I think.
Yeah, I think just if you do say something wrong, learning to just apologise and own your mistake, and just say sorry. You don't have to be defensive. You can just, you don't know what you don't know. So if you say something wrong, just be like, okay, I'm sorry that I said that. I won't do that in the future. I think is also really important and a mature thing to do. Because I think a lot of the time our reaction could be, oh, I know I didn't mean it like that. I did it. But instead just say, I'm sorry.
Yeah, absolutely. And I think it's quite liberating in a way to be able to have that conversation, because then you go, well, actually, I tried, I got it wrong, but actually the intention was there, the correct intention was there, and so it wasn't as horrific a mistake as I previously thought. So, but now I've learned from it, I can move on and make sure I don't do that same mistake again. So yeah, I think we all have to get it. We will all get it wrong at some point, but we just have to work hard to make sure we get it right.
Exactly. So a question I'm going to ask you, we also asked to our model, Tyler, who we had, and I think it's interesting to get everyone's perspective on this. So what does inclusivity mean to you?
That's a great question. And it's actually one that we included in our inclusivity research project, and got lots of really beautiful responses. I think that from an anatomy perspective, inclusivity for me means that everyone feels represented, everyone feels heard, and everyone feels seen. And I think as long as we work to make sure that we're constantly trying to improve that, then I think that's one of the key things. So long as everybody is represented as well as we can, we're not going to be able to have a direct representation of every single individual, but so long as parts of a person's identity are represented, then that allows everyone to kind of see the wonderful diversity that is anatomy. And that's one of the things I love about anatomy so much, is that diversity and that difference. And I think that's something that we should be celebrating and not trying to homogenize and put into boxes.
Yeah, definitely. I think that's a really lovely response. And like you said, everyone's response will differ because everyone has different characteristics about themselves that they don't see represented and they'd like to be included. And yeah, anatomy, it should be a way to show so much diversity, but instead I feel like we've kind of come down to the very basics and what we consider standard instead of showing everything and representing a more wide range of people, because like you said, we can't represent every single person or every single condition, but just showing that you're making the effort, I think, is really important too. Yeah, I think anatomy, it does have kind of the scope, because it is, for medical students at least, the first time I felt like I was actually doing medicine, because anatomy feels relevant and it feels like medicine, because a lot of it is kind of very sciencey to start off with. And then when I did anatomy, I was like, hey, yeah, this is what you buy, like books when you're little, and you've got the I think his name was like Billy Bones. He was like a skeleton, the magazine subscriptions you get.
Oh, the ones that I love it.
So I feel like that's, and you even have like Grey's Anatomy, just the name of the show. Anatomy plays such a role in culture, and then it's actually, you get to properly learn about it when you're doing dissection and your anatomy teaching. So it is important that it's representative.
Yeah, absolutely.
And then my final question is, what would you like to do regarding inclusivity in anatomy going forward? You're already doing so much, but kind of what are your future visions or plans?
Well, with the inclusivity in anatomy research that we're doing, we're wanting it to reach more people, to get a wider range of views. The initial questionnaires that we put out, it was initially a pilot, and we were just really surprised with how engaged people were with it. So it actually exceeded our expectations in the number of people that contributed. But it was just in English, so we do want to translate that into different languages to reach more people. And part of the point of that as well is not just for us to gather more information so we can publish more papers and get our names out there. It's actually about, it's really quite difficult to get into research, and there are lots of amazing anatomists around the world that would love to get into research, but struggle to because of various different, funding issues or logistical issues or whatever. and we're in the fortunate position that this research is really strongly backed by our medical school, our medical school values, and the universities. So we have that support. So what we want to be able to do is bring people with us. So by creating these kind of almost satellite research groups where we're kind of supporting people in doing this research, but in their native language, we can then sort of ensure that all of the structural and logistical components are all taken care of, so that they can then ask the questions that they need to ask that are related to their cultures, their geographic concerns, religious issues, all of that sort of thing. So they don't have to be forced to use the questions that we use. They can be asking the questions that they need to use. Because obviously we're only going to be asking the questions that come into our minds from our experience and our life experiences and that sort of thing. So we want to make sure that we can share that more widely, and so other people can get involved with research. And we also want to make a community for people that are interested in improving inclusivity in anatomy education. So we want to create like what's called a community of practice, because we know that there are lots of anatomists all over the world doing brilliant stuff with EDI and all of that. But sometimes it can be an uphill struggle, and sometimes because of workloads or logistics or a lack of support from institutions or governments or whatever, it can be really, really difficult and really challenging. So, but if we're able to work together, we can achieve so much more. And we can also implement positive change as well through things like grouping together and then challenging companies to do better and be more inclusive, make textbooks more inclusive. And if we have a group that are all saying the same thing, then there is power in that. And I feel like by working together, we can make a more positive impact on inclusion and representation in anatomy globally, and not just within our institution. So whatever we can do to help support that and support other people is basically what we want to do going forward.
That sounds great. And like you said, we are stronger together, especially if you're lobbying for change. It's much more impactful when you have lots of people together. And we have social media, we have video conferencing. There's so many ways to connect with people all across the globe now. So and it is important to see what people in other countries need, because I have no idea what anatomy teaching is like outside of the UK, really, or at least outside of the Western world. I don't really know how diverse their resources are and things. So I think especially translating the survey into different languages is a great step towards understanding other cultures, other curriculums and things like that.
Absolutely. Yeah. I think we have to step outside of the idea that European or global North based research is the best, and there is this kind of exclusive sort of perception about that, and it completely ignores an entire half of the globe, and it's utterly ridiculous. And there's so much that can be learned from each other, and some of the stuff, some of the findings will translate, and some of it will be really contextual, but it still is important. It still needs to be found out, and if we can do anything to help push that agenda and help people figure out the answers to some of these questions, then I feel like that would be a really wonderful thing to get involved in.
Definitely. Well, Siobhan, it's been lovely to speak to you. I've loved hearing about the work that you've done. It's all very inspiring, and I can't wait to see the published results of the survey because I think it'll be really insightful. If anyone wants to get in contact with you, where can they find you?
So you can get contact with me at siobhan.moyes@plymouth.ac.uk, through socials on at Petite Anatomist, and also through the Inclusivity and Anatomy Education website as well. Our contact details are on there. So yeah,
I'll link all
the
those
more
below
people,
if
the
you want to
merrier.
talk to you. Great, thank you so much.
Nice to meet with you. Thank you so much.